Hello everyone, and welcome to another Case of the Month session, which will actually be a Bugs of the Month session, which we haven't done for quite some time. This time we have the biopsy sample of a 6-month-old baby boy. This baby presents with disseminated maculopapular rash and aphthous lesions of the mouth, which had been ongoing for about a month. The baby is said to have received some sort of treatment for an allergic reaction, but when the symptoms did not resolve, and in fact he started developing, as the parents put it, swelling of the neck, the patient was referred to our hospital. Whereupon, during examination, it was found out that in addition to the disseminated rash and the aphthous lesions in the mouth, the baby had fever, hepatosplenomegaly and lymphadenopathy, and ultrasonography showed that there were actually parenchymal nodules in the spleen of the baby. And then one of the skin lesions was biopsied. Initially, a small punch biopsy was performed, which did not reveal a lot. So later on, they decided to excise one of the lesions in the skin, which is the specimen we are looking at right now. And over here you can see that the infiltrate actually involves predominantly the deeper dermis and also involves the subcutaneous fat tissue. Over here you can see that there is an infiltrate. There are several fragments which are all deep dermis and subcutaneous tissue. And when you zoom in, I'll just zoom in, you can see that this infiltrate is actually composed predominantly of neutrophils and these histiocytes. So you can see these. I know these are histiocytes because they stain with the CD68 and the 163. But furthermore, you can see that I'll show you that some of these cells have more foamy cytoplasm. In fact, some of them are even more vacuolated. And that's it. It's all macrophages and polymorphonuclear leukocytes, and there were also small groups of lymphocytes in between. So it's a histiocytic proliferation, and most of all it resembles what we'd call a reticulohistiocytoma maybe. So what we did was, as I said, we stained it for CD68, CD163, which were all positive, and we also did bug stains. Here, I'll show you. This is a close-up. You can see that they've got this foamy cytoplasm. Some of them have vacuolated cytoplasms, but most of it is foamy, and lots of neutrophils, so there's separation involved as well. So when we looked at the bug stains, pass and silver stains were negative, but with the acid-fast stain, we saw that these macrophages were actually stuffed with bacilli. I'll zoom in. You can see that there's acid-fast bacilli within the cytoplasm of these histiocytes. So the diagnosis is BCG-related histiocytosis, because this baby had a history of BCG vaccination, which in our country babies receive at about 2 months of age. And of course, because the baby had such a disseminated reaction after this vaccination, which is actually a live attenuated vaccine, the patient was investigated for immune deficiency, and it turned out that the patient had interferon gamma receptor 1 deficiency, which is a very important receptor involved in signaling of the macrophages via the T cells, and it's predisposes babies to intracellular pathogens, especially mycobacteria and salmonella and stuff. And it turned out that the patient's parents were actually related, and there was a history of death of a baby cousin as well in the family, which all point to immune deficiency, presence of immune deficiency, which is why we saw this particular lesion, BCG-related histiocytosis after vaccination, BCG vaccination. And it resembles a histiocytic proliferation, and this is something also that apparently we should keep in mind when we encounter a histiocytic proliferation in an infant, a young child. So thank you very much for listening, and hope you enjoyed this case. Bye-bye.